Hey everybody, welcome back to everything you need to know for NBME 26. This is the second section of the test. If you like this, like and subscribe. We're going to start on this little corner over here with Hardy-Weinberg equilibrium. Disclaimer, these questions are my own. Definitely go out, take the actual NBME, come back to this video, learn these concepts. So let's start. With Hardy-Weinberg equilibrium, what we need to know is the incidence of autosomal recessive disease is going to be Q squared. The carrier or heterozygote frequency is going to be 2Q for rare alleles. So that's the first thing to know. The second thing to know is that random mating prevents genotype-specific partner choice. So there has to be no inbreeding. This is necessary for Hardy-Weinberg equilibrium to occur. Also, 3 is going to be migration, so gene flow. 4, you got to have a really large population, right? Because small populations will suffer from what's called genetic drift, random chance, not mutation, so that skews your frequencies. And the last stipulation is high mutation rates. Think like ionizing radiation or advanced paternal age, right? These will continually reintroduce the alleles and break through equilibrium. So in the real life, you do have non-random mating, you have gene flow, genetic drift, and mutation. So the things that must be absent are non-random or assortative mating, mutations, migrations, small population sizes, and natural selection. Because those 5 forces act on the gene pool. And so your classic equilibrium, which is of course p squared plus 2pq plus q squared equals 1, will drift out of balance if you have 5 factors that are changing things around. So here's our practice question. We have a rare autosomal recessive lysosomal storage disease in 1 of every 25,000 live births. What's the carrier frequency for this disorder in the population? And we know that P is equal to 1 minus Q. So you do 1 minus whatever we got here, and you get 0.994. And then we can calculate the carrier frequency just by doubling that. And of course, multiplying it by 0.0063 because those have to add up to 1, and you get our final answer, which is option B. That would be the approximate carrier frequency, heterozygote prevalence. 2pq, where we find q from doing the square root of the disease incidence. We do 1 minus q to find p, and we multiply them together. There you go. Hardy-Weinberg, done. All right, for our next NBME question, we're going to be talking about how losing a teaspoon of albumin per day can pack 10 pounds of water onto your legs. I promise that'll make sense in a second, but this practice question, let's see if you can answer it. We have a 46-year-old man noticing eyelid swelling and progressive ankle edema for 3 weeks. BP 138/86, albumin 2.2, creatinine 1, 24-hour urine shows 9.8 protein. Which alteration in microvascular starting forces directly accounts for his edema? So let's imagine that your filter in your kidneys springs a leak, and then you spill out like 3.5 or more protein into, let's say, the toilet. Well, what's going to happen is you're losing that serum albumin. It's going to plummet, and you have capillary oncotic pressure. So that's the inward suction that normally reclaims the fluid is going to be collapsing, right? So hydrostatic pressure is going to win that kind of tug-of-war balance that's happening there, and it's going to drive the plasma water into the tissues. And so that's why this patient has the puffy eyes, and they have the socks that leave deep imprints. So the pivotal Starling change is going to be of decreased capillary plasma oncotic pressure. So it's going to be B, and you treat it with solving this underlying problem with your glomerular disease. And that will curb your, RAS system, especially if you give them like an ACE inhibitor. Give them an ACE inhibitor that'll stop the angiotensin 2. And if they need like a vaccination, give them the vaccination because that will also leak IgG. So let's read our little answer explanation here. It says, heavy proteinuria lowers plasma albumin, reducing capillary oncotic pressure. You lose that protein. Without that inward pull, the hydrostatic pressure pushes the fluid out, doesn't have the balance, leading to peripheral edema. So let's look at some trap answers and why they're wrong. So A, the interstitial hydrostatic going down. So that would actually favor fluid absorption, not edema, if your hydrostatic went down. So A is wrong. How about C would be increased capillary oncotic pressure. That would oppose filtration. So the edema requires the opposite. So it's not that. Venule permeability. So increased venule permeability is wrong because that describes your inflammatory edema. So nephrotic syndrome is going to cause low protein transudate. And lastly, E is wrong. Interstitial oncotic due to inflammation. That's exudated process, not protein loss. So in a patient on test day, you'll see serum albumin is like less than 3. They have hyperlipidemia and lipiduria. That's oval fat bodies under polarized light. They could have some pitting edema, CDs, and periorbital puffiness. So you see that edema. And then they might have a urine dipstick that shows like 3 to 4 plus protein, few cells and casts, and there's like a loss of immunoglobulin. So they have an infection risk, especially with encapsulated bacteria. And so just to be super clear about this, how this pathophys works is you got your kidneys and you have an injury that increases the pore or like the size or the selective charge of your barrier. And then you have albumin and other proteins that are going to pour into the urine. So there's like, nephrotic problems. Then your serum oncotic pressure falls below interstitial, and so you lose that reabsorptive pole. And so the net startling forces are going to favor the fluid transudate in the interstitial space that causes the edema that you see. Okay, cool. That is the answer and how this works for question 2 of section 2 of NBME 26. Of course, these questions are my own, but here we go. Okay, here's our next practice question. I call this the cherry red blackout. We'll see why in a second. We got a 62-year-old woman with paroxysmal atrial fibrillation that awakes to complete darkness in her right eye. All right, so I can't see. It's like that little vine. She denies pain, flashing lights, and floaters. Medications are metoprolol and aspirin, and she has been non-adherent to apixaban. Vitals are stable, visual acuity, no light perception. Phonoscopy shows a right eye with pale adamatus retina with a bright fovea. Okay, so bright fovea. Usually the bright fovea comes from the rest of the eye looking pretty like pallus or pallor. Basically, the rest of the eye loses its redness, and so by comparison, the bright red fovea seems bright and red. What is the most plausibly produced here that caused her vision loss? So malignant hypertension that would have bilateral flame hemorrhages and papilledema, and you don't see that here, so it's not it. B, that's the correct answer, is atrial origin embolus. It's going to be lodged in your central retinal artery. So you got that central artery that pours in. We got an embolus right over here. Have another video on this if you want to check it out. So you have the veins that are dilated and the vision is a lot less abrupt, right? So definitely not going to happen just like overnight. Vitreous hemorrhage of proliferative diabetic neuropathy. Vitreous hemorrhage, you're going to have like a hazy red reflex with your floating debris that occurs in advanced diabetes, not your classic like AFib patient here. This is a different appearance as well. The bright red is not what you see in vitreous hemorrhage. You see those floating debris. But this is actually kind of crazy, right? Because like imagine your whole world just goes dark in the blink of an eye. That's happens when you have a central retinal artery occlusion. And so like the retina turns basically ghost white, and the fovea is still fed by the chorioid, so it's still going to be like a candy apple red. And you can even do a swinging flashlight test if you want to see the afferent defect. Next thing you have to know for step. So we have a 19-year-old Mediterranean man, hemoglobin of 11, GA substitution abolishing the AG dinucleotide at the 3' end. What process is disrupted? Answer is going to be assembly of SNRPs that excise the intron. So this is like splice site mutations. You have little ninja edits, and they sabotage gene expression. So in a healthy cell, we have the tiny SNRP robots that zip the GU and the AG bookends of every intron. They snip them out, and they stitch the exons together. But if you have a single G to A swap at the AG receptor site, then it derails the spliceosome, and so the transcript can either keep the junk intron sequence or it can loop off an exon. Either way, you're shifting the reading frame, and so it's super problematic. So in beta globin, that glitch means that you have too few beta chains, and so the alpha chains are going to pile up, and the red cells are going to shrink, and then your patient will develop microcytic anemia with elevated HbA2 and HbF. That's classic beta thalassemia minor. So your splice sites are going to cripple your SNRNP-mediated intron removal. You got it? So let's talk about the trap answers. So this 5' capping kind of stuff, that happens co-transcriptionally at the first nucleotide. It's independent of any splice siting. So that's not right. This is correct. C, binding of the signal recognition particle to the nascent peptide. That's SRP binding. So your target's ribosome-bound peptide, not your RNA to the rough VR. So that kind of peptide binding is going to be ribosome-bound peptide stuff. Poly-A tailing, polyadenylation, that's going to require your ooh. You'll see why I said that in a second. Ooh. That's the signal near the transcript end, and it's unaffected by your intronic age. And of course, your nuclear export is going to be E, what they're getting at there. So you transport from the mature mRNA through the nuclear pore. That relies on processed mRNA export proteins, and the splicing occurs before the export. So before this is even exported, this is the splicing will occur. So your AG splice acceptor dinucleotide is essential for SNRNP recognition and preventing the loss of normal spliceosome, causing aberrant intron removal and frame-shifted beta globin. All right, so E's, modification of those spliceosomes. Super important. Need to know it for the step. Look at that. Making progress, guys, making progress. Just 6 more and we'll cut it up. If you guys want, maybe I could like sit down and do the entire video in like 5 or 6 hours. But for now, we're just doing, about 10 questions at a time. So this next question isn't too crazy hard, and so I'm just going to kind of explain the basic idea. We have a usually female patient who comes in, and there's some headaches, there's some fatigue, overeating, and anxiety, maybe kind of a lower BMI, but like 21 or so, And so we get the cycle of binging, purging, and acid burn. So you get the enamel erosion, normal BMI, that's what separates these two conditions. I can't say them out loud or else YouTube will flag the video or whatever. So we have Russell sign. That's the dorsal hands problem. The knuckles are going to scrape against your incisors when you're inducing gag reflex. And so you see Russell's sign. Very interesting. Also, bilateral parotid swelling is something you can see. Dental, enamel erosion. Hope you guys can kind of see these topics here. Gastric hydrochloride bathes the upper teeth, and that causes the dental caries. Metabolic alkalosis, loss of HCl, volume contraction, RAS, and then you get the renal potassium wasting. And then maybe like a normal to slightly even high BMI could be seen. Calories are absorbed before emesis, and then the weight often stays from the 18 to 30. Okay, so some associations, esophageal tears. So drinking a lot, intra-abdominal pressure could be raised there, forcing retching, causing the longitudinal kind of problems there in the esophagus. Primary amenorrhea, rare but irregular menses from stress. Yeah, so this stress-induced GnRH can cause problems with period cycles. Electrolyte-triggered hypokalemia, prolonged QT, and risk of sudden death, coexisting mood problems, serotonergic dysregulation. Some of these, syndromes you treat with SSRIs. Yeah, SSRI response, there it is, the fluoxetine, targeting underlying serotonin deficits, reducing your frequency. One thing to look out for is the BMI is like the 18 to 30, so it's kind of normal in this condition. Here's a practice question if you guys want to just pause it, but the answer here is going to be a dental enamel loss in the lingual surfaces of the upper incisors because you have that recurrent exposure of the maxillary teeth to gastric acid because of that self-induced activity there that dissolves the enamel, causing the smooth and glossy surfaces and high risk of dental caries. Why they're wrong, bradycardia, that'd be seen in that condition. Lanugo, again, same one. Galactorrhea, linked to prolactinomas, syncope, extreme, but less likely than your enamel. That's like the first kind of progression here. Okay, so if there's like a purging behavior, so we have to watch out for, and also the BMI above 18 differentiates it from this condition, which I can't say out loud because YouTube doesn't like it. Doesn't want me to say it out loud. So a way to kind of like make this stick home for you guys studying at home, 90% of these patients show silent dental damage before they confess of their kind of behaviors. So typically it's just you have an emotional trigger, some binging, guilt-driven, vomiting, and then it melts the enamel until the cavities will kind of grow. And so Russell's sign at the knuckles, and also you have your, chipmunk parotids, and that's how you kind of get this diagnosis. Very sad. Okay, the next thing we need to know for step 1, we're just going to do 4 more questions and we're done. So just hang in there. You're almost there. Let's talk about toxins, especially with tetanus. So how do you get tetanus immunity? So I'll zoom in. You have your IgG antibodies against the tetanospasmin. Now, here's something really fascinating that I learned while researching this topic. 1/1000th of a gram of tetanospasm can snap every single muscle in your body into spasmic mode. 1/1000th of a gram. And so how do we stop this? Well, we give them toxoid vaccines. Unless, of course, you don't believe in vaccines because you're really, really smart. And those will flip this entire tetanospasm nightmare on its head. Now it's no big deal. Chemical detoxification basically teaches your B cells to craft a snug fitting IgG match. And so the antibodies then patrol the bloodstream and they can just handcuff the live toxin before it even hitches a ride to the spinal cord. So let's see if we understand this. Here's a practice question. 30-year-old carpenter slices his palm on a rusty chisel. So our carpenter is slicing his hand. His donor immune globulin is going to provide an instant toxin shield. So there's no need to wait for his own boosters to kick in. Basically, protection targets the exotoxin, not the cell wall capsules of the flagella. So if you see any word like tetanus vaccine or a passive antitoxin or even spastic paralysis, you should think of the neutralizing antibodies against the exotoxin. And the exotoxin is just a toxin that's released by the living bacterial cell into its surroundings. So the answer is going to be your heat labile exotoxin. So here's our little explanation. Tetanus contains IgG that binds to tetanospasm, blocking its interaction to the snare proteins and preventing spastic paralysis. Okay, so that's how it works, but what about the other ones? Capsule polysaccharide. It's really good to get in the habit of knowing why each one is wrong. Capsule. So there we think like C. tetani is going to be non-capsulated. Polysaccharide vaccines target your S. pneumoniae and Neisseria meningitidis. Peptidoglycan, that's a structural cell wall layer. So antibodies here do not stop your neurotoxic action, just a cell wall layer. So it's not going to be your exotoxin like C is. Our flagella in here, so the motility protein, C. tetani has flagella, but neutralizing them won't avert your paralysis. And so good try, but no. Pilus adhesion, so that's kind of referring to like your fimbriae. So that's going to mediate your adherence and many gram negatives, but it's irrelevant to tetanus. Tetanus is really just going to be exotoxin mediated. And so the last things I want to tell you kind of is that there's a toxoid series at 2, 4, 6, 15, 18 months. And also you get from years 4 to 6, you get this booster. And one of the first symptoms you get is trismus, so it's locked jaw. And the treatment is going to be, you can give a metro and benzo for the spasms, but really what you need are these antibody titers with protection. So cell-mediated immunity is going to play a minimal role here. So there's no capsule, no flagellar relevance. It's just the toxin is the singular villain for this problem, right? Just the toxin is all you need to worry about for tetanus. All right, so toxin is the answer. All right, here's our next question. Just gonna zoom on out. Take a little stretch break, do some push-ups. Who knows what you want to do? And then we'll dive right in. Our 6-year-old girl refuses an IV line before tonsillectomy. She's kind of maybe afraid of it or something. And so the anesthesiologist decides on inhalational induction with a gas. Whose blood gas partition is 0.42. Ventilator sessions are unchanged. What property accounts for the rapid onset. So basically, how can you have rapid onset with your anesthesia medicine? Well, what we notice is that it's 0.5 or less. So some inhaled agents are going to drop this child into blissful unawares of anesthesia. It's going to be low solubility into the bloodstream. So the low solubility means the blood saturates quickly, allowing the alveolar partial pressure to rise. So maybe a way to think about this, like the bloodstream, streamy blood, is a sponge. So a small non-absorbent sponge that has low solubility gets saturated instantaneously. And so alveolar pressure will skyrocket and the drug will rush to the brain and it flips the consciousness switch off. And so you crank up that ventilation, minute ventilation, or you dial down the cardiac output and it's even quicker. And so the way to think about this is that solubility dictates the speed. So lipid solubility dictates the strength. And so even if you've got a kid who's afraid of needles, you should pick the agent that barely dissolves into the blood at all. So C, low solubility into the bloodstream. Because if there's a low blood gas partition coefficient, then it's going to reach the brain really, really quickly. And the induction speed is determined by the solubility and the ventilation and the cardiac output. So think about it like more breaths, more molecules that are delivered to the alveoli. The low cardiac output will speed up the induction because less blood removes the anesthetic from the lungs. And so there's this blood gas partition coefficient. That's the ratio of the anesthetic that's dissolved in the blood versus the alveoli. So if it skips the blood, like the lower will be saturating the blood sooner. And the closer are, the faster. And I know this can be confusing, so we'll talk about some of these trap answers. High minimum alveolar concentration. So the high MAC, that indicates low potency. High lipid solubility, that correlates with your potency. Vapor pressure at room temperature. That makes the delivery harder and it can actually slow the onset. Potent muscle relaxing effect, that's beneficial, but it's completely unrelated to the speed that these things are disseminated out. So we pick a gas that does not like to dissolve in the blood so that the blood doesn't soak it up and it goes straight from the lungs to the brain. Boom, child's knocked out. That's how to think about it. Remember the blood, spongy, big thirsty sponge. If it soaks up the gas, it takes a long time to fill. But if it's lowly soluble, gets saturated instantaneously. And for these guys, you want them to sleep before you place the IV. So you just knock them out real quick. Desflurane, nitrous oxide, very low blood solubility, super fast onset, and halothane, isoflurane are going to be high solubility, so slower on. All right, so we're going on to our next one. You see a picture of the brain, and they say, hey, we got a dude who's got some memory problems, anxiety, short-term memory problems. Where is the problem going to be located at? It's going to be like right over here, and it's just going to be like your limbic system. So your memory and emotional regulation, limbic. That's going to include the amygdala, hippocampus, parahippocampal gyrus, and where is it located? Mesial temporal lobe. Okay, so some memory going on there. Big thing to look out for there is going to be some radiation or chemotherapy. Okay, next question, only 2 more and we're done. Which camera do you guys like better? Is this one better? Do a couple push-ups and let me know what you think. So here's the next practice question. 55-year-old carpenter, dull pain in his right butt that disrupts his sleep. X-ray shows lesions of the right iliac wing, cortical expansion rings and arcs, onion skin reaction. Biopsy shows lobules of hyaline type cartilage, pleomorphic hyperchromatic chondrocytes. What's the best explanation? It's going to be chondrosarcoma. Axial skeleton is what this is associated with. Also the calcification pattern, slow growing malignant cartilage producing tumor. So it's a cartilage producing tumor in your pelvis that slowly reaches like the size of like a grapefruit. And it reaches that size until you even start to feel anything. And this occurs in kind of middle-aged individuals. Unlike the osteosarcoma, which is in the teenage years, your chondrosarcoma is going to be very slowly moving, kind of creeping, depositing cartilage that calcify into the rings and arcs that you see on the x-ray. So you see that hyaline matrix that's peppered with your chondrocytes. Hard to describe, but it's just like kind of pink background and it's in the axial skeleton. So 55-year-old iliac lesions on the butt, chondrosarcoma, calcified arcs, that's pathognomonic for it. Some of the answer choices, chondroblastic osteosarcoma, so that's going to be osteoid in addition to cartilage as well, typically in adolescence. And chondroma, that's benign, small hand of the bones, asymptomatic. Ewing sarcoma, small round blue cells, translocation 1122. Onion skin, periosteum, that affects your children. Simple bone cyst, it's going to be fluid-filled, metaphysis, a metaphyseal lesion in the kids, central lucency without calcified matrix. Okay, there we have it. Next question. So here, this is like a lumbar axial scan. And the question is, where are we going to enter into the canal? It's going to be right there. Laminectomy. So an excision of the lamina, ligamentum flavum opens the canal. Practice question. Somebody's got an L5 to S1 herniation. Surgeon needs a window to visualize the fecal sac and the S1 nerve root. Which structure is resected? The lamina. Lamina forms posterior roof of the spinal canal. Reforming it provides a direct midline access to the dura while sparing nerve roots housed laterally. So A, that forms the lateral canal wall. So drilling here would risk your like a fracture and root injury. Vertebral body, that's the anterior column. So access would require retroperitoneal. So that's silly goose. You're not going to go that way. Superior articular facet, excessive removal will destabilize your motion segment. So only if the foramen needs enlargement would you go like this. And the transverse process, that's insane. That's a muscle attachment site. So maybe for lateral stuff, but you wouldn't even get to be exposed to the canal. So I don't know why you're doing it on that side. So think of like the canal it's like a train tunnel with an easily removable tin roof. And that roof is the lamina. So the lamina is the pedicle's the wall, right? So you're just going to enter right in here. Okay, if you find this series helpful, like and subscribe, and I'll continue to make more content. We're going to be going through all of these questions for NBME 26 if you guys are into that. Also, for those who subscribe, you'll be entered into a drawing for our free medical interface that is going to be launching soon. We'll see you guys in the next video. And then take care of yourselves out there. Have a good day.